Every year, approximately 805,000 people in the United States have a heart attack, one every 40 seconds. What the statistics do not communicate clearly enough is that in a substantial number of those cases, the body sent warning signals hours, sometimes days, before the event. Signals that were either missed, misinterpreted, or consciously dismissed because they did not match the dramatic chest-clutching image most people carry of what a heart attack looks like. That gap between what the body signals and what people recognize is what this video is about. A heart attack is not a spontaneous event. It is almost always the final step in a process that has been developing over years, sometimes decades, inside the coronary arteries. Understanding that process and understanding what the body does in the hours before a major cardiac event gives you something that the standard conversation about heart disease rarely offers: a usable window for intervention. Before we get into the warning signs, let me ask you something directly. Have you ever experienced a symptom? Chest discomfort, unusual fatigue, jaw pain, something that felt wrong but resolved on its own, and decided it was probably nothing? Leave a comment with your age and what that experience was. I read every one, and those descriptions are exactly what shapes what I cover in future videos. Here is the biology first, because without it, the warning signs do not fully make sense. Your heart muscle is supplied by three main coronary arteries: the left anterior descending, the left circumflex, and the right coronary artery. Each one branches progressively into smaller vessels that deliver oxygenated blood to the heart muscle continuously. Unlike skeletal muscle, which can tolerate periods of reduced blood flow, the heart muscle has almost no tolerance for oxygen deprivation. It is working every second of every day, and it needs its fuel supply maintained without interruption. The process that leads to a heart attack is called atherosclerosis, the progressive buildup of plaques inside the walls of the coronary arteries. These plaques are not simply fat deposits. They are complex structures containing cholesterol, immune cells, calcium, and fibrous tissue that accumulate over years in response to endothelial damage. The endothelium is the single-cell thick lining on the inside of every artery. When it is healthy, blood components pass through without adhering. When it is damaged by high blood sugar, smoking, chronic inflammation, or mechanical stress from elevated blood pressure, it becomes a surface that things stick to. Think of the endothelium like the lining of a water pipe that has been treated with a non-stick coating. While the coating is intact, mineral deposits and debris pass through without adhering. Once the coating is scratched and roughened, deposits begin to accumulate at those damaged points. Over years, those accumulations grow into the plaques that narrow the coronary artery and reduce the blood flow available to the heart muscle. What causes a heart attack specifically, rather than just chronic coronary narrowing, is usually a plaque rupture. A plaque that has been stable for years suddenly develops a crack or tear in its outer fibrous cap. The body responds to that rupture the way it responds to any tissue injury, by sending platelets to seal the breach and initiating the clotting cascade. In a coronary artery that is already partially narrowed, that clot can grow rapidly enough to completely block blood flow. The heart muscle downstream of the blockage begins to die within minutes. That is a myocardial infarction. The hours before that complete blockage, when the plaque is unstable, when small clots are forming and partially dissolving, when blood flow is intermittently reduced, is when the warning signals appear. Most people experience at least some of them. Most people do not act on them in time. Here are 5 warning signs that research and clinical cardiology have consistently identified as preceding heart attacks, often hours to days before the event itself. Warning sign 1, chest discomfort that is not what you expect. The classic heart attack image, sudden crushing chest pain, represents one presentation and not always the most common one in the hours before a full event. What people more frequently report in the prodromal period, the warning period before the actual infarction, is something less dramatic and therefore more easily dismissed. The sensation is often described as pressure, tightness, heaviness, or a squeezing sensation in the center or left side of the chest, not a sharp stabbing pain. More like someone has placed a moderate weight on the sternum and it has not fully lifted. It may come and go. It may last a few minutes and then resolve. It may feel different from any chest discomfort you have experienced before, less localized, less clearly pain, more of an uncomfortable fullness. The mechanism is myocardial ischemia, reduced oxygen delivery to the heart muscle. When a partially blocked coronary artery cannot supply enough oxygenated blood to meet the heart's demand, the muscle sends distress signals through cardiac nerve fibers. Those fibers converge with other sensory nerves at the spinal cord level before reaching the brain, which is why cardiac pain is often diffuse and hard to localize precisely. The brain cannot always pinpoint where the signal originated. What makes this warning sign particularly important to understand is the pattern. Ischemic chest discomfort in the prodromal period tends to be triggered by exertion and relieved by rest. You notice it climbing stairs or walking briskly, and it eases when you stop. This is called stable angina when it is predictable, but when the pattern changes, when it begins occurring at rest, when it lasts longer, when it takes more time to resolve, that change in pattern is what cardiologists call unstable angina. Unstable angina is a medical emergency that precedes heart attack in a substantial proportion of cases. The critical point, chest discomfort that resolves on its own, is not reassurance. It is information. The resolution means the clot partially dissolved or the spasm relaxed, not that the underlying problem has been addressed. The same instability that produced that episode will produce the next one, and the next episode may not resolve. Warning sign 2. Pain or discomfort radiating beyond the chest. One of the most consistent findings in retrospective analyses of heart attack patients is that in the hours before the event, many reported pain or discomfort in locations that had nothing to do with their chest, and that they therefore did not associate with their heart. The locations that appear most frequently, the left arm, specifically the inner aspect from the shoulder to the wrist. The jaw and lower teeth, often described as an ache rather than sharp pain. The left side of the neck or throat, the upper back between the shoulder blades, less commonly the right arm or both arms simultaneously. The anatomy behind this is the same convergence mechanism described above. The cardiac nerve fibers that carry pain signals from the heart share pathways at the spinal cord with sensory nerves from the arm, jaw, neck, and upper back. The brain, receiving a signal from that shared pathway, does not always correctly identify the heart as the source. It assigns the pain to wherever it has learned to expect signals from that pathway, which is typically the arm or jaw, not the chest. This referred pain pattern is well documented and consistent enough that cardiologists treat unexplained jaw pain or left arm aching in a middle-aged or older adult as a potential cardiac symptom until proven otherwise, particularly when it occurs without a clear musculoskeletal explanation and in combination with other symptoms. The diagnostic error that costs lives is the person who experiences jaw pain or a left arm ache, attributes it to a dental problem or sleeping position, and does not connect it to the mild chest pressure they had earlier the same day. The symptoms do not need to occur simultaneously to be related. They may be separated by hours. They are pieces of the same prodromal picture. Warning sign 3. Unexplained breathlessness at rest or with minimal exertion. Shortness of breath that seems disproportionate to what you are doing. Getting up from a chair, walking to another room, lying flat, is a warning sign that is frequently underreported by patients and underemphasized in public health messaging about heart attacks. The mechanism: when a portion of the heart muscle is receiving inadequate blood flow, its pumping efficiency decreases. The left ventricle, the main pumping chamber, may not empty as completely with each contraction. Blood backs up from the ventricle into the pulmonary veins and eventually into the lungs. The lungs, now partially congested with backed up blood, have reduced capacity for gas exchange. The result is breathlessness, not from a lung problem, but from the heart's reduced ability to pump blood forward efficiently. Think of it the way a drainage system backs up when a downstream blockage reduces flow. The problem is not at the point where you see the water accumulating, it is at the obstruction further along. In older adults, breathlessness is frequently attributed to deconditioning, age-related lung changes, or existing conditions like COPD or mild heart failure. This attribution is sometimes correct, but a change in breathlessness pattern, new onset, sudden worsening, or breathlessness that occurs in situations where it did not previously, warrants evaluation, particularly in the context of other symptoms on this list. Women in particular are more likely than men to present with breathlessness as a primary or sole symptom of cardiac ischemia, with chest pain either absent or less prominent. This is one reason heart attacks in women are diagnosed later and treated later than in men. The symptom pattern does not match the culturally dominant template, and both patients and clinicians are slower to recognize it. Warning sign 4. Unusual fatigue, specifically the kind that does not make sense relative to activity. In the days before a heart attack, a significant proportion of patients, particularly women but men as well, report a fatigue that is qualitatively different from normal tiredness. Not the fatigue of a long day or poor sleep, something heavier, more pervasive, that does not lift with rest in the usual way. This fatigue has a physiological basis. When the heart is working harder to compensate for reduced coronary blood flow, pumping faster or with more force to maintain cardiac output despite compromised efficiency, the body diverts resources accordingly. The skeletal muscles, digestive system, and other non-essential systems receive reduced perfusion as the body prioritizes keeping the heart and brain adequately supplied. That redistribution manifests as a systemic heaviness, a disinclination to move, a sense of effort attached to activities that are normally automatic. Research published in the journal Circulation found that in a study of women who had experienced heart attacks, 70% reported unusual fatigue in the weeks preceding the event, making it the most commonly reported prodromal symptom, more frequent even than chest pain. That finding has been replicated and is now incorporated into cardiac awareness programs specifically targeting women over 60. The clinical challenge is that fatigue is ubiquitous. It accompanies dozens of conditions and is a common feature of normal aging. The distinguishing feature of precardiac fatigue is its sudden onset or abrupt change in character, its resistance to rest, and its occurrence alongside even minor physical effort. When a person who has been sleeping normally and living at their usual activity level reports an unexpected, unexplained heaviness in the preceding days, particularly alongside any of the other symptoms on this list, that pattern is worth taking to a cardiologist rather than waiting to see if it resolves. This is a reasonable point to pause. The information in this video represents the kind of mechanistic, evidence-based discussion that too often stays within clinical settings rather than reaching the people who need it most. If this is the level of detail you are looking for in health content, consider subscribing. The goal is content that equips you to have more productive conversations with your physician, not to replace those conversations. Warning sign 5, cold sweating, nausea, or lightheadedness without an obvious cause. These three symptoms are frequently grouped together in cardiac literature because they share a common mechanism: activation of the autonomic nervous system in response to cardiac distress. When the heart muscle is ischemic, receiving insufficient oxygen, the body activates a stress response through the autonomic nervous system. Adrenaline is released. The sympathetic nervous system increases heart rate and redistributes blood flow. The vagus nerve, the parasympathetic counterpart, may simultaneously activate in a compensatory response that produces nausea, sweating, and a drop in blood pressure. The result is the combination that cardiologists describe as a vagal response: pale, sweaty, nauseated, and lightheaded simultaneously. The cold sweat, diaphoresis in medical terminology, that accompanies cardiac events is distinct from the sweating of exertion or heat. It occurs at rest, is often described as clammy rather than warm, and tends to appear suddenly. It is the body's emergency cooling and redistribution response activating in the absence of physical activity, which is exactly what makes it clinically significant. Nausea before a heart attack is frequently attributed to something eaten, a stomach bug, or anxiety. This misattribution is common enough that some patients take antacids or anti-nausea medication in the hours before a heart attack, believing their symptom is gastrointestinal. The delay this creates in seeking cardiac evaluation is measured in minutes and hours that directly affect how much heart muscle is permanently damaged. Lightheadedness in this context reflects either a transient drop in blood pressure as the heart's pumping efficiency decreases or the vasovagal response described above. Unlike the lightheadedness of standing up too quickly, which resolves within seconds and has a clear positional trigger, precardiac lightheadedness tends to be sustained, may worsen with any exertion, and occurs without a positional cause. The pattern that should eliminate any doubt about seeking immediate evaluation: two or more of the symptoms on this list occurring together, particularly if one of them is chest discomfort or pressure of any intensity. The combination is more diagnostic than any single symptom alone. Now, the practical questions: what is actually damaging the coronary arteries over years, and what does the evidence say about modifying that process? The endothelium, the non-stick lining described earlier, has three primary enemies that account for the majority of coronary artery disease in older adults. Chronically elevated blood glucose is the first. Glucose cannot enter endothelial cells without insulin. When insulin is insufficient or when cells become resistant to its signal, blood glucose remains elevated while endothelial cells are simultaneously starved of their fuel. Starved, energy-depleted endothelial cells lose their structural integrity. They become irregular, lose their smooth surface, and create the rough patches where plaque formation begins. This process starts in the pre-diabetic range, years before a formal diabetes diagnosis. A glycated hemoglobin, HbA1c, test reflects average blood glucose over the preceding 3 months and catches this damage range elevation that a single fasting glucose reading may miss. An HbA1c between 5.7% and 6.4% indicates prediabetes and represents active endothelial risk that is correctable with dietary modification. Smoking is the second. Every cigarette delivers compounds that cause direct chemical injury to the endothelial lining and simultaneously increase blood viscosity, making platelets more likely to aggregate and clots more likely to form. The combination of a damaged vessel wall and thicker, stickier blood creates the precise conditions under which coronary plaques rupture and the clotting cascade produces a complete arterial blockage. The elevated coronary risk from smoking begins to decline meaningfully within 1 to 2 years of cessation and continues to decrease over time. This is not a minor point. It is one of the most reproducible findings in cardiovascular epidemiology. Hypertension is the third, with an important nuance that is frequently misunderstood. Chronically high blood pressure accelerates endothelial injury and plaque formation and is one of the primary drivers of the vessel wall weakening that leads to both ischemic and hemorrhagic events. But in a coronary artery already significantly narrowed by plaque, a myocardial infarction often does not occur at the moment of highest blood pressure. It occurs when pressure drops at night during sleep, when the reduced driving pressure can no longer push blood through a critically narrowed segment that also has a partially obstructing clot. This nighttime pattern is why some people wake with chest pain or are found symptomatic in the morning after going to bed feeling well. Managing blood pressure means targeting a stable, healthy range, not simply avoiding high readings while ignoring low ones. If you have experienced any of the warning signs described today, even once, even briefly, even if they resolved, there are 3 evaluations worth asking about at your next clinical visit. The first is a coronary calcium score, a low-radiation CT scan that quantifies the amount of calcified plaque in the coronary arteries and provides a direct measure of atherosclerotic burden that is independent of cholesterol levels. A score of 0 in someone over 60 is genuinely reassuring. A score above 100, or any score that has increased from a previous measurement, indicates active plaque accumulation and changes the risk conversation considerably. The second is a resting and stress electrocardiogram. A resting ECG can identify prior silent myocardial infarctions, rhythm abnormalities, and conduction changes that suggest coronary disease. A stress ECG, performed while walking on a treadmill at increasing intensity, can reveal ischemia that is not apparent at rest, showing the pattern of electrical change that occurs when the heart muscle is insufficiently supplied during demand. Atrial fibrillation, when the upper chambers of the heart beat chaotically rather than in coordinated rhythm, is both a risk factor for clot formation and stroke and is frequently associated with underlying coronary disease. Holter monitoring, a continuous 24 to 48-hour ECG recording worn during normal daily activity, captures arrhythmias that a brief clinic recording misses. The third is a full lipid panel with particle size analysis, not just total cholesterol and LDL. Oxidized LDL, the form of low-density lipoprotein that has been chemically altered by free radicals, is the form that adheres to damaged endothelium and initiates plaque formation. Standard lipid panels do not measure oxidized LDL or particle size. An apolipoprotein B measurement, or an LDL particle number test, provides a more accurate picture of coronary risk than LDL cholesterol alone, particularly in people with normal total cholesterol but persistent risk factors. The central point that clinical cardiology has established clearly and that public health messaging has been slower to communicate: a heart attack is not a sudden, unpredictable catastrophe in the majority of cases. It is the end of a process that has been producing signals in the vessel walls, in the coronary circulation, and in the symptoms described above, for months or years before the event itself. The 5 warning signs: chest pressure or discomfort that comes and goes, pain radiating to the arm, jaw, neck, or back, unexplained breathlessness, unusual pervasive fatigue, and cold sweating or nausea without a clear cause are not exotic or subtle. They are well documented in the clinical literature. What is missing is not the knowledge. It is the expectation that these signals are worth taking seriously before they escalate. The 72-hour window after experiencing prodromal cardiac symptoms, the period when intervention can prevent a complete infarction, is not a guarantee. But it is a real opportunity that exists because the biology of plaque rupture and thrombosis takes time to reach completion. Using that window means treating a resolved symptom with the same urgency as an ongoing one. It means not waiting to see if the discomfort returns before deciding whether to call. The references for every mechanism and study described today are in the description. Bring them to a clinical conversation. The conversation is worth having, and you now have the scientific foundation to make it specific.